Hi everyone, my name is Dr. Sonia Craig. I'm a respiratory and sleep physician working in Liverpool, and the purpose of this educational video is to give you some more information about obstructive sleep apnea to go alongside the group CPAP setup that you're taking part in today. I hope that it'll be really helpful to you, and at the end of the video, of course, there'll be time to ask questions. So we're going to be talking about obstructive sleep apnea, what it is and how we define it, how we investigate it, a bit about management and treatment, although that will be the second part really of the setup day today, and a little bit about driving and DVLA concerns. So you might wonder why we're worried about obstructive sleep apnea, and a lot of patients and medical professionals think, well, it's just a bit of snoring, it's nothing to worry about. And consequently, it does take a long time sometimes to get into the service and be referred. But it's really quite important. It's very prevalent, so latest estimates suggest 1 in 8 people in the whole world, about 1 billion people actually have sleep apnea. It can be associated with other problems such as high blood pressure, risk of heart problems, risk of diabetes, and palpitations such as atrial fibrillation. And of course, it does affect your sleep quality, and it breaks up your sleep, and therefore the lack of sleep and lack of good quality sleep can affect your daytime functioning and your work and lead to accidents such as road traffic accidents, accidents at work, and major socioeconomic consequences. So what is sleep apnea? So sleep apneas are a group of related conditions. So there are 2 different types, obstructive and central, but we're mainly talking about obstructive sleep apnea today. And that is the most common form, and that is where the airway, your own airway, starts relaxing and the muscles start relaxing and narrowing the tube that you're breathing through. This can happen on the edge of sleep or when you're very relaxed, but mostly this starts to happen when you start falling asleep. Initially, what you will hear is a noisy breathing, which we would call snoring, and that is the airway just relaxing and narrowing. The air becomes turbulent and it starts making a noise. Then obstructive sleep apnea is one step on from that, where instead of just narrowing, the airway actually closes off completely and it's completely blocked. The brain detects this, thankfully, and will then wake you up and you start breathing again. But the brain is having to break up sleep in order for you to keep breathing, and that's what leads to the fragmentation of your normal sleep pattern. So if someone was lying beside you listening, they would hear noisy breathing and snoring, then silence, then a sort of a choking noise as the airway opens again as your brain wakes you up, sort of a noise, and then you may start snoring and then you may stop breathing again. So that's obstructive sleep apnea, quite a noisy process. Central sleep apnea is very different, and it is usually due to the brain stem at the back of the head being affected by some other condition, either a medical condition such as heart failure or some medications such as painkillers with opiates in them. They can affect the ability for the brain to detect your breathing pattern, and your breathing becomes quite erratic. But it's more of a silent process and a quiet process, so very different from obstructive sleep apnea. So obstructive sleep apnea has a few bits of terminology that you might need to be aware of, especially if you're filling out forms. So the actual obstructive sleep apnea is what we see on a sleep study, and that's a medical definition. So apnea means stopping breathing, obstruction is due to your airway closing off while you fall asleep or when you're asleep. But the term obstructive sleep apnea syndrome is actually due to the symptoms that you get. So the syndrome is obstructive sleep apnea on a sleep study plus certain symptoms that you will complain about and be aware of. So it may be that your sleep is so broken up that you feel sleepy the next day and you're not able to concentrate, or you may have problems remembering things, and just, as I say, not able to carry out your normal activities. The other symptoms that are associated with part of the syndrome is something called nocturia, which basically means getting up to pass water at night. And this is because the bladder filling at night is affected by obstructive sleep apnea. So it's very common that people will complain of getting up to pass water at night, and that is part of the syndrome. And usually treating the sleep apnea helps with that. We use the term apnea to mean full cessation of breathing, so complete stopping breathing, but it may actually be partial, so the airway closes off partially and reduces the flow through the pharynx. So partial obstruction is called a hypopnea, and if you're in Scotland, the terminology is the sleep apnea hypopnea syndrome, so it may be that you'll hear that term. So in summary, the obstructive sleep apnea syndrome is the symptoms of sleep apnea, so your airway closing off and narrowing either partially or completely. Then your brain waking you up to get you to breathe again. So this is an arousal, awaking from sleep, and it breaks up your sleep. And then you have the daytime consequences of the sleep fragmentation. So mainly excessive daytime sleepiness and failure to be able to concentrate and so on, as we've mentioned. But that is the obstructive sleep apnea syndrome. The causes of obstructive sleep apnea are probably fairly obvious, but as we put on weight, we tend to put on weight in certain areas of the body, such as our tummy, but also around the neck, either externally that you can see it, but also there's little fat pads beside the airway, which can get bigger as we put on weight, and they narrow the airway from the inside that you wouldn't be able to notice. Also, our face shape can affect whether we develop obstructive sleep apnea. And obviously we're all completely different, and so a smaller jaw can make it more likely that you develop obstructive sleep apnea. Some patients have large tonsils, which can affect their airway, and nasal problems such as a blocked nose or sinusitis or hay fever can mean that you open your mouth a lot more when you're asleep, which disturbs sleep generally, but also dries the back of the throat and makes it more likely that snoring and sleep apnea would be worse. Then there's other things like having an underactive thyroid, drinking alcohol, which is a muscle relaxant, smoking, which swells the back of the throat, and then in the menopause, again, sleep generally can become a bit more unstable, and the way that we put on weight after menopause differs, so that can make it more likely. And then there are a few unusual causes. So the way we investigate this is by a number of tests, and there are various different types of tests that can be carried out to investigate sleep apnea. One of the reasons that I put this slide in is that some of our patients will come back to us and say, I don't believe I've got obstructive sleep apnea. But diagnosing obstructive sleep apnea is actually fairly simple. It can be as simple as something called oximetry, which is a simple finger probe test. But the problem with that is that if it falls off or it fails, then we've no other way of telling us whether you've got obstructive sleep apnea. Therefore, we tend to use a more complicated test, which is what is now recommended by NICE, which is something where we're looking at oximetry on the finger, but also body movement, the actual breathing mechanism, and so you've got a number of signals so that we can get as much information about your sleep as possible. The severity of the sleep apnea is measuring the number of episodes or stopping breathing episodes. So it's actually measured by the computer, and often it's fairly accurate, but we do check that to make sure that it's not misreading it or there's an artifact there. So the stopping breathing events are measured by two things called the ODI and the AHI, and that just basically means either the number of dips that this computer is detecting on the sleep study, so dips meaning the oxygen level dropping down, or something called apnea-hypopnea index, and that is the number of total stopping breathing episodes, complete cessation, or a hypopnea where the oxygen is reducing and the airflow is reducing, and that is called a hypopnea and is also counted in the calculation. However, apart from the actual sleep study, it's also really important that we ask lots of questions about how this is affecting you. So your daytime symptoms and sleep quality is also really important, because we're not just treating a sleep study, we're treating you. So as part of the questions that we ask you about how you feel, we use something called the Epworth Sleepiness Score, or Epworth Sleepiness Scale. And this has been used worldwide and basically asks you how likely you are to fall asleep in certain situations. However, it differs from patient to patient, and your normal may be someone else's abnormal. So for instance, you may score 8, which is within normal range in theory, but you might feel very sleepy with that, and you might find that after we treat you with CPAP therapy that improves and goes from 8 till 4, for instance, whereas some other patients who have got a very high Epworth sleepiness score are not particularly bothered by it. So it's not the score necessarily itself that's important, but just also how you feel. So as well as the Epworth sleepiness score, we will be asking you other questions. So this is a few examples of what a sleep tracing looks like. The top left hand one is normal, so as you can see the oxygen level is fairly stable, so the little line has a few bumps but nothing to be worried about. Then just to show you what severe sleep apnea looks like just on an oximetry tracing, the one on the right, top right, is severe obstructive sleep apnea. So it's incredibly different, and it shows that the oxygen level is going up and down multiple times through the night and is obviously waking the patient up each time. So that would be really disturbing to sleep, as you can imagine, and very different from a normal tracing. So it is fairly straightforward to detect sleep apnea, just even with a simple oximetry tracing. Then the other are more unusual. At the bottom left is if I took you up to the top of the mountain, your breathing would become a bit more unstable. And the Cheyne-Stokes ventilation is a type of central sleep apnea associated with having heart problems. So the management of obstructive sleep apnea is not just with CPAP, although that is the main treatment, and that is what you're going to be set up with today. But there are other things that you can do that would help with your sleep quality and also reduce the snoring and sleep apnea. So for instance, if you had a low thyroid or underactive thyroid, we would advise that would be treated, and that's why we also do some blood tests as part of your assessment. We'd advise you to stop evening alcohol and any sedatives if possible, because that also affects the airway muscles and would make snoring worse. Stopping smoking is always advisable, as it would reduce sleep disruption and also reduce the upper airway swelling that you get with smoking. We would advise you to lose weight, as losing weight will help with other obesity related problems, but we realise it can be very difficult. Mounjaro is becoming more available, but there's still a number of restrictions on its use, so it may not be possible for you to have Mounjaro. But a change of diet can help, so looking at the blood sugar diet by Michael Mosley might also be helpful, or looking at the NHS website for healthy eating advice. There are a few other devices, posture training, so that is if you only snore or have sleep apnea when you're on your back. We can tell you about that if you wish. Dental devices are an alternative to CPAP for mild patients, but they're currently not fully available on the NHS, so it might have to be through a dentist. Surgery, rarely, to help with the jaw position, and that is possible. And there's also continuous positive airway pressure, which is what you're going to be taught about today. This slide is just to show you that NICE, which is the NHS group that look at cost effectiveness of various treatments have looked at CPAP therapy and felt that it is cost effective, and therefore that means that this is all available on the NHS. You do not have to go privately, you do not have to buy your own masks. We will provide you with adequate equipment. All we would ask is that you use it, and or at least try to use it, but it is very effective treatment, and which is why it's been recommended by NICE. This is just some imaging to show you how CPAP works. So essentially it just blows air into the back of the pharynx. So on the left hand side you can see that the airway is very narrow, and then on the right hand side in the rectangular box you can see that the airway is a lot bigger, and that's because CPAP is holding the airway open like pneumatic scaffolding. So that's just what it does. That's how it works. Pressurized air. Of course, we know that using CPAP is not like taking a tablet. The first stage of CPAP management is actually getting you onto a machine, so at least we got you to that point, so that's good. Then we know that it will take some time to get used to it, and the sleep team here are specialists in this, and we are here to answer any of your questions regarding this and to support you through that. But it's very unusual for people just to suddenly use CPAP and have no issues whatsoever, so we do expect that. So please do ask us for help if you need it. We're also not going to tell you off if you don't get on well with it, and we're not here to torture you. So if you find that you're really struggling, please reach out to us and we will try to help you as much as possible. You may find that you just can't get on with it, and at that point you may want to return it, but we have a process for that where we would assess you and try and give you advice beforehand. So just a little bit about the DVLA regulation. So patients are very concerned often about and worried about driving if they're diagnosed with obstructive sleep apnea. So it's all based on obstructive sleep apnea syndrome. So not just the fact you've had a sleep study that shows obstructive sleep apnea, but the fact you've got some symptoms that are affecting you, either sleepiness or inability to concentrate, or vigilance. Vigilance, the ability to detect danger. So your sleepiness has to be likely to impair your driving, and it may be that you drive very occasionally and you're not particularly sleepy, in which case you don't need to tell the DVLA. It's your decision to decide whether you're safe to drive. I will not be informing the DVLA, and it's your responsibility to inform them if you feel that you're unsafe to drive. But you've got about 3 months to get everything sorted out if you do tell the DVLA, and we would always try and get you back on the road as soon as possible. But I would advise you to look at the Sleep Apnea Trust Association, which is a patient association that has a lot of information about driving and the DVLA, more than I can give in this talk. So there's a lot of information on their website if you're concerned. And of course, if you are concerned, we will also give you some advice regarding that in your sleep centre. So do reach out to your sleep centre if you're concerned. So that's the end of my presentation. Please do ask the sleep team if there are any questions regarding what we've said today, but they're now going to take you through your CPAP machine and fit you for a mask. There'll be lots of information available either online or in your pack, and we will be giving you links that you can have a look at this video again if you wish, and also some information about the CPAP machine itself. There's also a lot of information in the Sleep Apnea Trust Association website, as I've mentioned, and also the NHS website regarding obstructive sleep apnea. I hope you enjoy the rest of the setup session.